Good afternoon, everyone. Are you guys able to hear me? Yes. Okay. Hey, Terry, how are you? Alrighty. Well, let me share my screen with y'all so that we can go ahead and get started on this lovely afternoon. Okay, show screen. Okay, are you guys all able to see my screen today? Perfect. Okay, so we're going to go ahead and get started. So today we have just some basic reminders. We're going to go over chapter 120, which has to do with bioterrorism, also chapter 34, which are intravascular devices, and then also next week assignments. I did get quite a few emails letting me know that people were going to be missing today's class, so I didn't do a group member spotlight for today, since we do have quite a few people out today. Okay, so some of our reminders. Okay, so we have had a couple of new people join the group, so I just want to make sure that we go over what the necessary tools are in order for you to be successful in studying for your CIC exam. There's definitely people who do not utilize these tools. They may use, an APIC course, or they may opt to study in other manners, but we have found that these are kind of like the most important items in order to prepare for your CIC exam, and specifically for this group. So the first thing would be your APIC text, and so these are volumes 1, 2, and 3. You're able to purchase it online. I believe they did run out of the hard copies. They did have them on sale for quite some time, but I believe that they did run out of the hard copies. So you can still get it online. And then also the certification study guide, which is what I use to develop the infection prevention and control study plan and workbook, which is basically what we're basing all of our sessions off of. The different work assignments, and then the take-home assignments for the different modules and questions are all coming from this certification study guide, unless I put together like an online quiz of like I did for week 5. So I do plan on doing another one of those coming up shortly. But for the group, this is really what you're going to need in order to make sure that you're keeping up and that you're able to be successful. Now, I just want to make sure that we all understand that it does take commitment in order to prepare for your exam. We do meet for 1 hour on Fridays from 2 to 3, and it's really important to participate and to try to answer the questions. Also ensuring that you're completing your readings outside of class. If you're coming in and you're participating, it's great, but I feel like it's way more beneficial if you've actually conducted your readings and you kind of know what we're going to review and what we're going to go over. It's estimated that we're going to spend over 120 hours preparing for the exam in the next 6 months, or in these 6 months of our cohort. So just keep that in mind. It is a lot of studying and it's a huge commitment. Additionally, you should make sure that you have supervisor support and support from your facility or from your employer in preparing for the exam. And lastly, just keeping in mind that the cost for the CIC exam, for some of you, it may be covered through your facility. For some of us, specifically those working in public health, the cost for that exam may not be covered. So just wanted to, quickly go over a couple of reminders. Also, just to remind you guys once again, Patty Montgomery's Washington CIC study group has already started back up. They're having their lessons and they're on Wednesdays at 3 p.m. If you're interested in joining her study group, you're able to register at the following registration link. And then the APIC resources, once again, this is where you can find them. I don't think the texts are longer, they're no longer available when I last looked on the APIC website, but you can still get the online text. And then, of course, the CIC Resources, they have a practice exam for $50, which does include 70 questions. I did actually purchase that exam. It was one of the last exams I took prior to taking my CIC exam. It doesn't go over whether you got the answers correct or not. It's a pass or fail. And they also don't go over what you missed. So I would definitely recommend that if you are planning on purchasing it, that it's kind of one of the last things that you do, because it's not like with the textbook where you're able to go back and review what concepts you're missing and everything. So okay, so it's really important that you guys try to get your homework submitted. I know we're all really busy and there's a lot of stuff going on, but I'm really trying to track all this data and the averages for what we're getting in the class so that I can know when we have a little bit of time later on when we're not reading as many chapters, I can kind of go back and touch up on those concepts that you guys are missing. The scores that I received so far were pretty, they weren't too bad, but there were some that were scoring pretty low. And so I want to make sure that if there's something that I'm missing or that I'm not providing you guys, that I'm able to go back and make sure that we review that information. So if you did not submit your homework, which is page 7, and you don't have to get fancy, you don't have to type in the answers, you can just fill it out, in pen or pencil, and then just take a picture or scan it in. It does not need to be fancy. Just try to make sure that you're getting those in on time so that I can provide you guys with that data and let you know how the group is doing overall in the course and kind of what we need to review. So for this week, week 8, you had 3 chapters. You had chapter 5, infection prevention and behavioral interventions, chapter 34, which is intravascular device infections, and then chapter 120, which is all about bioterrorism, emerging infections, and pandemics. So we're going to go ahead and we're going to start with chapter 120, which has to do with bioterrorism. And so we'll go ahead and get started. So infectious disease disasters are events that involve a biological agent or disease and that result in mass casualties, such as a bioterrorism attack, a pandemic, or an outbreak of an emerging infectious disease. Infectious disease disasters are different from other types of disasters because they increase the risk of communicable disease spread during and after the incident. They also involve the need for specialized mitigation, planning, and response interventions to prevent and control the spread of the disease. So it's not like your run-of-the-mill um, uh, infectious disease. It does involve a lot of really specialized actions and planning and preparedness in order to make sure that your healthcare facilities and that your communities are able to deal with a bioterrorism attack. It's multidepartmental and it's a multi-departmental and multi-agency endeavor that encompasses the 4 principles of emergency management, which is mitigation, preparedness, response, and recovery. Emergency management is one of the chapters in the APIC text. I don't believe I made it one of the mandatory readings. It is important, it's definitely important, but I feel like for this exam, there is not as big of an emphasis on emergency preparedness. You may have a couple questions on bioterrorism attacks, but I don't recall there being a lot of questions on emergency preparedness. So some common characteristics of bioterrorism agents, and the way that they're going to ask you about these common characteristics is they may tell you which of the following is not one of the common characteristics of bioterrorism agents, or they'll tell you which of the following is a characteristic of a bioterrorism agent, which is why it's really important for you to make sure that you have these understood and memorized for the exam. So it's the ability to be dispersed in aerosols of 1 to 5 micron sized particles, which can penetrate the distal bronchioles. The ability to deliver these aerosols with simple technology. That's very important. The feasibility of these agents, if delivered from a line source like an airplane, upwind from the target to infect large numbers of a population. And also the ability to spread infection, disease, panic, and fear. So these 4 are the common characteristics of bioterrorism agents. So the majority of them are going to share these 4 characteristics, which is why it's really important to make sure that you just review that information. Now, as far as methods of dissemination, you have different routes that you can choose to go with as far as methods of dissemination. If someone is planning a bioterrorism attack, these are some of their options. The most likely route is going to be an aerosolized release, which it's an aerosolized release, so you're releasing the particles. Other methods are oral, which is an intentional contamination of food or water supply, percutaneous, an infected animal or vector, like a release of infected fleas, and also human-to-human spread. So individuals infected with a communicable disease walking among a crowd of healthy people. And an example that they give you in the APIC text is the anthrax attacks of 2001, which proved even physical objects such as letters can be used to help spread biological agents. So, bioterrorism versus biological warfare. Can any of you guys tell me what the difference is between bioterrorism and biological warfare? Okay, so Carrie Harder says biological warfare is aimed at the military operations, right? So bioterrorism is going to be the intentional use of a biological agent or derivative of such an agent to inflict harm or death onto a civilian population. And then our biological warfare differs from bioterrorism in that the target of the attack is military personnel. As far as the APIC text, they kind of refer to both of them together as bioterrorism. But I just feel like it's important for us to make sure that we do know the differences between those two. So, as far as bioterrorism preparedness helps to mitigate potential negative outcomes and is required by healthcare and public health regulating agencies as part of a comprehensive emergency management program. So, like I said, emergency management is a part of the APIC text, and I definitely encourage you guys, if you have time, to make sure that you do read it and go through it. However, I feel like a lot of the kind of some of the key information that you'll need for the exam is covered in chapter 120. Chapter 120 is pretty long. Chapter 34 is pretty long. So please keep in mind I can't possibly go over every single bit of information included in those chapters in 1 hour. There's just no way. Um, so, anywho's, let's keep going. So, the future potential impact of bioterrorism depends on the agent that is used, the amount that's disseminated, the dispersal method, the weather and release conditions, the pre-existing immunity of the exposed population, and how quickly the attack is identified. So a way that they could ask you about the potential impacts of bioterrorism is they can essentially put these different types of answers and tell you which one could be a potential impact, right? And then they'll give you a list, like the agent used, the amount disseminated, the dispersal method, and they may throw some different sentences or information that does not necessarily match with the future potential impact of a bioterrorism attack, and uh, you just have to know the information. I know it seems like there's so much that you need to know for the exam, and it can be a little bit overwhelming. But don't worry, it's just you just have to practice, and you have to get used to the questions that they'll ask you. Once you have kind of a baseline information of these chapters, it'll be so much easier for you to be able to determine what the answers should be. So, as far as bioterrorism attacks, you have different categories. You have Category A, Category B, and Category C. So, Category A is going to pose the highest risk to national security because these pathogens specifically can be very easily disseminated or transmitted from person to person. They result in high mortality rates. They also have the potential to cause public panic and social disruption, and they require special preparedness actions. So Category A, it's really important that you know all of the pathogens in Category A because they will ask you which of the following pathogens, is a Category A pathogen, and they may put, hepatitis A, ricin toxin, salmonella, and tularemia, and you know that they could all be bioterrorism agents, but if you're not sure which category they're assigned to, unfortunately, those are the kind of questions where, yes, you can definitely try to use what you know about the pathogens to figure out which category they would be classified into. However, I think this is more just straight kind of rote memorization of which category they're assigned to. You have questions which will require for you to just kind of know information and not require much analysis. And so this is a kind of setup in which they could ask you which category do these different pathogens belong to. So for category A, we have anthrax, botulism, the plague, smallpox, tularemia, and the viral hemorrhagic fevers. For category B, they pose the second highest risk because they are moderately easy to disseminate, result in low mortality rates, and require enhancement of diagnostic and surveillance capability. And so here we have West Nile virus, calicivirus, Hep A, ricin toxin, salmonella, and diarrhegenic E. coli. And then for category C, these are the emerging pathogens that could be engineered for mass dissemination because they are available, they're easily produced and disseminated, and they have the potential for high mortality rates. And this is where you're going to find your influenza, your SARS, rabies, MDR, tuberculosis, yellow fever, and then your tick-borne hemorrhagic fevers. I like this chart because I think it really does break it down very easy so that you're able to kind of determine, what the different categories stand for, what they mean, and so that you're also able to see what pathogens go assigned with them. Another way that they can ask you about these different categories is they can give you the definition for what a category A, category B, category C pathogen is, and you essentially have to decide which category it belongs to. So if they tell you that it poses the highest risk to national security, you should know that that's a category. It's going to be classified as category A. Now, from your APIC text, this is the chart that that is available through the online text. And so it's different from the one that I previously showed you because it doesn't have that information that allows you to better understand the categories, which is why I wanted to provide you guys with that chart. But these are the pathogens that they're going to want you to know. So you should know these, especially your category A pathogens by heart. You should know where they belong to. And the easiest way to do this is going to just be to make flashcards and to put the pathogens on one side and then the category on the back. Additionally, it would be really good for you to have an idea of what these different pathogens do, what their pathogenesis is like. So it's not enough for you to know, oh, anthrax is a category A agent. What's the symptomology that accompanies anthrax? Can you have skin infections? Essentially, what do they cause? What is that pathogenesis? What does that pathophysiology look like? So that you're able to answer questions correctly. While some of it is really rote memorization, you do have to be able to not only know this information, but apply it to the questions that they're going to ask you. So in the text, they did go over the 6 phases of a pandemic, and I do remember I specifically had a question on the 6 phases of a pandemic, so I wanted to make sure that we covered that in this in this presentation. So, can anyone tell me what number 1 would be? What would the first phase of a pandemic be? I'm glad you like this game, Maria. I actually haven't played Pandemic, but my EPI program manager has it in her office. So we say D. Okay, so Carrie said D. No or very limited human-to-human transmission. I'll wait till I get a couple more answers. The very first phase. Elizabeth says F. There's quite a few of you on the line, so I know you guys are there. So y'all better participate. Okay, so it seems that the group is kind of split. Well, you got it right, Elizabeth, so you are thinking pretty hard. The group is kind of split between F and D, so that's pretty good. So the first phase is going to be there's a low risk of human cases. So what is number 2, now that we know it's a low risk of human cases? The next phase would be which letter? Okay, so the majority of you guys are saying D, which is actually incorrect. So the next phase would be A, that you start out with a low risk of human cases and you're moving over to a higher risk of human cases. Okay, so phase 3 would be which one? We're running out of options. So it should be getting a little bit easier. Okay, so we have some C's and some D's. And D is actually the correct answer. So you're going from low risk of human cases to higher risk of human cases to no or very limited human to human transmission. So what would be phase 4? C. Okay, very good, very good. And then what is phase 5? Okay, everybody put E. And then the last phase would be efficient and sustained human to human transmission. So let's look at what these phases, the 6 stages of a pandemic look like. So we have the interpandemic phase, which are going to include your phases 1 and 2, which is when a new virus in animals could be introduced. There's no human cases, right? So you have a low risk of human cases being your very first stage. Then you have a higher risk of human cases. Then you have your pandemic alert. And then that's when you have no or very limited human to human transmission, right? 4 would be evidence of human to human transmission. And then when you're reaching those, when you're in that pandemic stage, there's evidence of significant human to human transmission, efficient and sustained human to human transmission. Now, in your text, so in the APIC text, they do mention the World Health Organization has. So the WHO, 6 stages of a pandemic. They do mention the World Health Organization's 6 stages of a pandemic. So let's just quickly look at that. Let's see what that looks like. Okay, so if we look at WHO, and we try to get, you know, let's get a little bit close here. So you see here that this is an example of pandemic influenza phases. And so you have phases 1 through 3, which are predominantly animals. There's infections. There's few human infections. You have phase 4, which is going to be sustained human to human transmission. Phase 5 and 6, which is the full-on pandemic, which is widespread human infection. And then they have the post-peak, which is the possibility of recurrent events, and then the post-pandemic, which is disease activity at seasonal levels. So out of the bioterrorism or infectious disease disasters or events, your pandemics are going to be the ones that are going to have the highest morbidity and mortality, specifically relating to the public's health. So it's really important to ensure that you do have those emergency preparedness plans in place at your healthcare facilities. You know, in public health, we have entire departments that are specifically focused on emergency preparedness, and and it does involve working in a lot of teams, and that I feel is something that is very similar in healthcare and also public health. So just making sure that as an infection preventionist, you are aware of those emergency preparedness plans, that you are familiar and that you're involved in those conversations, because you do need to be knowledgeable. And I mean, if you think about it, if you have a highly infectious disease coming into your healthcare facilities, you're going to be one of the first people, hopefully, hopefully, that is going to be notified, specifically being an infection preventionist. And they're going to look for you. They're going to look to you to guide them on what those appropriate steps are going to be for isolation, for management of what's going to happen with this patient, what we need to do to protect our healthcare workers. And so it's not just about memorizing things for this exam so that you're able to pass it. It's really about ensuring that you're embracing this information and trying to bring it into your, your everyday work and your everyday life, and trying to, be the best IP and the best epidemiologist that you can be. So that's the 6 stages of a pandemic. So let's keep it moving. So question 1, which of the following bioterrorism agents has the highest fatality rate? A, Q fever, B, ricin, C, smallpox, and D, severe acute respiratory syndrome. I'll give you guys just a minute to figure it out. We have quite a few different answers for this one. Quite a few different answers. So let's go through the bottom here just really quickly before we review the answer. So variola virus is going to belong to which infectious disease above? Q fever, ricin, smallpox, SARS. Smallpox, correct. What about Coxiella burnetii or Burnetii? I'm going to go with Burnetii. Q fever, very good. Now what about, okay, well, SARS-CoV, come on, I'm kind of giving that away. And then castor beans is going to be your ricin. So when you're asked a question like this on the exam, the majority of you guys are stuck between, ricin and smallpox. So when you're thinking about these types of questions, you really need to look at what they're asking you. They're asking you about which one has the highest fatality rate, right? And so I don't know the fatality rates for these pathogens specifically off the top of my head. I cannot tell you, and I probably will never be able to tell you, like, oh, Q fever has a fatality rate of 20%, ricin has one of 60%. Like, I don't know that. And more than likely for the exam, you're not going to know that either, right? That would be, I mean, if you do, good for you. But if you don't, then you need to find ways to figure out the answer. So for me, I would think about how these pathogens are transmitted, how you're going to come into contact with these pathogens. And the riskiest one up here, I would think, would be smallpox, right? Because that can be transmitted from person to person. Ricin, that's going to take some work for you to come into contact with. Q fever, I mean, if you're friends with bunnies, quite possibly, but you just want to like Elizabeth said, Q fever is much more limited. Yes, you're wanting to think, like here they're not necessarily asking you, do you know these fatality rates? They're wanting you to use what you know about these pathogens to come up with an answer that makes sense. So the correct answer is going to be smallpox. Now let's go over our rationale. So smallpox is an acute, contagious, and sometimes fatal disease caused by the variola virus and marked by fever and a distinctive progressive skin rash. The majority of patients with smallpox recover, but death may occur in up to 30% of cases. Bioterrorism agents can be separated into 3 categories depending on how easily they can be spread and the severity of illness or death they can cause. So if we go back, sorry, let me go back. So if we go back and we look at our list, we have Q fever, ricin, smallpox, and SARS. And okay, I am not going through all of that. So if we go back to our bioterrorism agent list, we see that smallpox is going to be one of our category A agents, which means that they're going to pose the highest risk to national security and to your patients. They're going to have, they're going to be the most easily transmitted, and they're going to result in the highest mortality rates, right? So out of this list, the only one that is a category A agent was smallpox. If we look at the APIC list, let's see, Q fever, category B. Where's ricin? Ricin, where are you? Ricin, category B. Q fever, ricin. What was the other one? Smallpox and SARS. SARS, I think it's a category C. Yeah, see, category C. So like I said, they don't necessarily want to make sure that you know all of these percentages and that you're able to, have this information memorized. They want you to use the information that you know. So when you're answering these questions, ask yourselves, what do I know about these diseases and their, their pathology, okay, their transmission. So question 2, you have been notified that a possible smallpox patient has been identified in your community. The patient is being admitted directly to your facility. Whew, I would be so stressed. What type of precautions should your personnel take when caring for this patient? Elizabeth says, wait, it's been eradicated. Oh, yes, but the CIC exam doesn't care. They can still ask you questions about it. So we have different options here as far as isolation precautions. So I'll give you guys a second to think. Okay, so everyone put the same answer for this one, which is A, which is airborne isolation with negative pressure ventilation. So for these type of questions, they're really wanting to make sure, they're not asking you about the category of the agent. They're really wanting to know, do you know about transmission and do you know how to prevent it? And they could do this with any other, disease. They could do this with any other type of pathogen. So so Elizabeth said, is it droplet? Is it droplet precautions? So if it was transmitted via droplets, do you think a more appropriate response would be to place the patient under droplet isolation rather than airborne isolation? Because that's the way that we need to be thinking. We need to be thinking transmission wise. What kind of isolation measures would you put in place? So for tuberculosis, we're also going to use airborne isolation because of its transmission. So it's not really just, it's not just knowing what these pathogens are, but really having a good idea of how they're transmitted and what that pathology looks like, pathogenesis. So the rationale, generally, so airborne isolation with negative pressure ventilation. So generally, direct and fairly prolonged face-to-face contact is required to spread smallpox from one person to another. So smallpox can be spread through direct contact with infected bodily fluids or contaminated objects such as bedding or clothing. Patients must be placed in airborne isolation with negative pressure ventilation. And then here we have an airborne isolation precaution sign. This is from the University of North Carolina. They have a lot of really great resources available, and we actually utilize these signs, not specifically airborne so much, but contact in their droplet signs when we're going out to healthcare facilities and conducting, follow-up for outbreaks or even infection control assessments. We bring out some of these signs and leave them with our nursing homes and sometimes with our hospitals. Okay, question 3. Infection prevention and control priorities in a disaster include all of the following except A, sterilization of instruments and disinfection of equipment, B, obtaining medication from vendors not affected by disaster, C, maintaining ability to prepare food for employees and victims, and D, drinking water for employees and victims. Okay, so we have a lot of answers. The majority are B, and then we do have some C's. So the correct answer is going to be obtaining medication from vendors not affected by disaster. So what is our rationale? Emergency management of infectious disease disasters is a multi-departmental and multi-agency endeavor. In most situations, chemoprophylaxis will be important during an infectious disease disaster. The healthcare facility's pharmacy department should be instrumental in preparing for disasters by stockpiling medication or making arrangements to obtain additional supplies. In the event that local resources are exceeded by need during a large-scale infectious disease disaster, medication and supplies can be obtained from the CDC's Strategic National Stockpile, SNS. So, the key words here were, let me use my little pen, infection prevention and control priorities, right? That was really the key. So obtaining medications from vendors not affected by a disaster, that is really going to be the responsibility of your pharmacy to ensure that they have the medication that's necessary. Now, a couple of people, the majority of you were between B and C, so maintaining ability to prepare food for employees and victims. So they do talk about in the APIC text about different responsibilities of infection prevention and control, and you want to ensure that if the drinking water and the food that you're preparing for employees is going to be adequate and is going to be and is not going to make people sick, right? So Elizabeth said food contamination and spoilage. Exactly. So that is going to fall under your responsibilities as well, because we're in a disaster situation. This is not your, where your regular every day to day. Your roles are going to change. And your responsibilities are going to change when you're responding to a disaster. You may need to oversee things differently. And so that is why C is definitely going to tie into infection prevention and control priorities during a disaster. Okay, so question 4. Of all the common types of agents used for bioterrorism, one type is primarily transmitted to others by contaminated food and water. Which type is that? Okay, so everybody put, okay, wait, almost everyone put B. So we were stuck between A or B. Interesting. Okay, so let's go through this. Let's talk about this. So, can does anybody in the group feel comfortable talking about tularemia? You can just type yes into the answer box. Terry said no. um, okay, so okay. I get it, guys. I get it. Nobody's comfortable. Okay, so let's go over tularemia. So tularemia is a disease of animals and humans, which is caused by the bacterium Francisella tularensis. And so rabbits, hares, rodents. Um, I personally think rabbits and rodents are very cute, but I know some of you may not. And so it's kind of easy for me to remember this because it's associated with cute animals. I'm sorry. Let me calm down. Rabbits, hares, and rodents are especially susceptible and often die in large numbers during outbreaks. So humans can become infected through like several routes, including tick and deer fly bites. So we have a tick here and fly over here, skin contact with infected animals, ingestion of contaminated water, inhalation of contaminated aerosols or agricultural dusts, right? So that's kind of what our little tularemia situation is there. And so here, I'm sure you guys are already thinking, well, what the heck, Luce? What do you mean? It is transmitted, by contaminated water, which I completely agree. Yes, that should have been one of your possible answer choices. However, once again, here they coming for our edges. The key word is primarily. So your primary method of transmission. Your keyword is primarily. And so you need to be careful when you're reading this. Do not speed through the test. Don't, like, you have to find these little traps that they're going to put in the questions. And so in this one, it's going to be primarily. So cholera is, it's an acute diarrheal disease, which is caused by Vibrio cholerae. And this is characterized by profuse watery diarrhea, vomiting, leg cramps, rapid loss of body fluids, and dehydration and shock. And without treatment, death can occur within hours. And as we know, cholera is going to be primarily associated with contaminated food and water. Now, Q fever, and this is Vibrio right here, this purple one. And Q fever is caused by Coxiella burnetii. And this bacteria is going to infect goat, sheep, cattle, and they can be found in the birth products like the placenta, amniotic fluid, urine, feces, and milk of infected animals. Now, anthrax is definitely a little bit different. It's an infectious disease caused by a gram-positive rod-shaped bacteria known as Bacillus anthracis. It's more rare, definitely, but people can get sick with anthrax if they come into contact with infected animals or contaminated animal products. And so, once again, the correct answer is going to be cholera. Okay, so I had a couple of yes, bunnies. Tularemia can be spread through a variety of ways, running over animal hides, infected food and water, and soil that has been aerosolized. That was from Liza. And then Elizabeth said, Q fever, you can get it from aerosolized feces if you're downwind from a farm. Whew, that's stressful. So here we have, the correct answer is going to be cholera. Okay, question 5 is, which of the following infectious disease disasters pose the biggest potential threat to the public's health in terms of morbidity and mortality? Okay, so our answers are going to be it's okay if you guess, that's okay. That's why we're reviewing the information. But this is something that was mentioned in the book, I think 3 times throughout the chapter. So I felt like, okay, I've seen this 3 times. That probably means they want me to know it. And I would say you definitely keep an eye on that when you're reading your text. If you see concepts that are coming up constantly, which you will, as you continue to read these chapters, you'll see that they're going to always touch on certain things throughout the text. That means they want you to know it. So the correct answer is going to be pandemic. And I did mention this earlier when we were going through the 6 stages of pandemic. So I was trying to throw you guys a bone. So the rationale is, of all types of infectious disease disasters, pandemics pose the biggest potential threat to the public's health in terms of morbidity and mortality. As experts in the fields of communicable diseases, infection prevention, and epidemiology, infection preventionists are poised to be at the forefront during an infectious disease disaster. As such, IPs must embrace their role as experts in infectious disease emergency management and assist their healthcare facility or community in becoming better prepared to rapidly, appropriately, and effectively respond to an infectious disease disaster. All right, now we're going to jump into intravascular device infection. This is going to be a chapter that will definitely be a lot easier for our nurses in the group than it will be for our EPIs who do not have clinical experience. Chapter 34 is extremely important. You do need to make sure that you are familiar with intravascular device associated infections and intravascular devices specifically. This is extremely important, not just for the exam, but when it comes to you conducting infection control assessments, when you're conducting your rounds, if you're an infection preventionist, ensuring that you are familiar with what some of the bundles and the measures that you can do to prevent intravascular device associated bloodstream infections. So there are two major sources of intravascular device-associated BSIs. So number one is going to be the colonization of the intravenous device or catheter-associated infection. And number two is going to be contamination of the fluid administered through the device or infusate-associated infection. So contaminated infusate is the cause of most epidemic intravascular device-associated BSIs. In contrast, catheter-associated infections are responsible for most endemic intravascular device-associated bloodstream infections. So some key facts when you're obtaining blood cultures to guide antimicrobial therapy, it's essential to use sound infection prevention and control laboratory practices, including attention to skin disinfection, collection of an adequate amount of blood, and careful handling of the specimen. Then you want to make sure that this next portion is just recent studies have shown that consistent application of high-yield preventative interventions such as bundles can lead to substantial and sustained reductions in facility rates of intravascular device-associated bloodstream infections. Do we have any IPs on the line that can talk a little bit about maybe what their bundles look like for prevention of BSIs at their facility? I think it would be really great for some of the EPIs on the call and even other IPs. And it could just be very brief. I don't know if we have any IPs on today. Let's see. Let's see if we have any brave souls. Melody. Melody, you want to talk? Wonderful. Okay, let me find you. So let me unmute you. Okay. Hello? Hello? Melody. Oh, Melody doesn't have voice access. Makes me so sad. Okay, Deborah. Let's see if Deborah can talk to us. Deborah?
Hello.
Hey, we can hear you. Can you talk to us a little bit about your BSI bundles?
Yes, as far as our BSI bundles, we don't routinely change. We change every 7 days. We use the alcohol infused ports on everyone. We do CHG bathing daily on those patients. And we have a needs assessment checklist that we do every day for those devices. So we have a lot of things that we do as far as a bundle.
Yeah, that's wonderful. That's a really good insight into what a bundle looks like. Thanks, Deborah. Appreciate it.
Like for the ventilator, which is a device too, we have the head of the bed up, the protein pump inhibitors, the BE prophylaxis, and we
Your
have that.
sedation vacations.
Yep, sedation vacations, and also a needs assessment daily. That's one of the most important things in all of our bundles. We assess it daily and make sure it's still needed and get it out in a timely fashion.
Perfect. Thank you so much.
You're welcome.
So yes, guys. So that's what we're referring to when we're using the word bundle. Now, I'm familiar with that word obviously because I've read through the text. I'm not an IP myself, but when we go out and we conduct infection control assessments and we're going through the ICAR form, we do have to ask what bundles do you have in place? What do your bundles look like for CAUTI prevention, for CLABSI prevention? And so let's see what some of our other participants have put in here. So Melody said full patient draping for insertion, following an insertion checklist, choosing a vein where the risk is the least, ensuring that you scrub the hub before any insertion into the line. Tamika Anderson said hand hygiene, PPE, scrub the hub. Yes, scrub the hub. So Great, great. This is really good feedback from our infection preventionists on the call. So once system-based practices have been maximized, the judicious use of novel technologies such as anti-infective catheters, antiseptic dressings, and antibiotic lock solutions can promote further reductions in rates of intravascular device-associated bloodstream infections. So pathogenesis of intravascular device-associated sepsis. So microorganisms can essentially cause infections, can cause catheter-associated infections, but in order to do that, they first need to gain access to either the extraluminal or the intraluminal surface of the device. Once they have access to that, they're able to adhere, they're able to reproduce and subsequently become incorporated into a biofilm that allows sustained infection and hematogenous dissemination. Did I say that word right? Hopefully. Microorganisms can gain access to the bloodstream by one of three mechanisms, and these are really important for you to make sure you know. One, skin organisms invade the percutaneous tract, probably facilitated by capillary action at the time of the insertion or in the days following. So what is one thing that you can do right here for number one that you can do to prevent organisms from being introduced during a percutaneous injury? Elizabeth, exactly. Appropriate skin antisepsis. Clean skin with chlorhexidine. Very good. Skin antisepsis is going to be our prevention measure for number one. So two, microorganisms contaminate the catheter hub and lumen when the catheter is inserted over a percutaneous guide wire or later manipulated. What is a prevention measure we can put in there? So we have scrub the hub. Yes, scrub the hub. And then three is organisms are carried hematogeneously to the implanted intravenous vascular device from remote sources of local infection, such as pneumonia, or it could even be some other type of skin infection. So what would be one that what would be a prevention measure for number three? And I want you to think, not just pneumonia, it could be something else. Exactly, Deborah. CHG bathing, which is going to be your chlorhexidine bathing. Very good. So let's talk a little bit about long-term versus short-term intravenous vascular devices. So wait a minute. Luce, you switch the titles. I apologize. This should be short-term. This should be long-term. I will fix this before I send it out to you guys. So for our short-term, they're going to be in place for less than 10 days, and these are going to be your peripheral intravenous IV catheters, arterial catheters, non-cuffed and non-tunnel central venous catheters. Most device-associated BSIs are of cutaneous origin. Cutaneous meaning cutaneous. Skin, yes. Cutaneous origin from the insertion site and gain access extraluminally. That's a fun word. Occasionally intraluminally. And once again, that is short term. Do not pay attention to this title. This title is lying to you. I lied to you. Okay. This should be short, and this should be long. Okay. Now for our long-term intravascular devices, they're going to be in place greater than 10 days, and they're going to be your cuffed Hickman and Broviac type catheters, subcutaneous and central ports, and also your PICC lines. Contamination of the catheter hub and luminal fluid is the predominant mode of transmission for your bloodstream infections. Now, if you do not have a lot of clinical experience. Like I've told you guys before, my clinical experience, the majority of my clinical experience, I actually obtained being a scribe, a medical scribe in the emergency department. But even still, there are times when I can get a little bit confused when it comes to the different types of lines and the different types of catheters, and it can be a little bit overwhelming. So, if this is something that you're not fully understanding, there's a lot of really great resources on YouTube. There's really just nothing like trying to get out there and shadowing some IPs in your community. And this is specifically for our epidemiologists. I know our infection preventionists are dealing with this on a regular basis. When you're conducting your rounds, you are familiar with this terminology, and a lot of you are nurses. So, of course, it's something that is going to be a strength when it comes to this exam. But for our EPIs, I actually reached out to Florida Hospital here in Orlando, and I think we had 5 or 6 epidemiologists that actually went over to different campuses in the Central Florida region to shadow um, to shadow um, infection preventionists and to get an idea of what their day-to-day is like, what they're dealing with. Us IPs want to follow you EPs. Yeah, you can come over anytime, Deborah. You know, you're just right around the corner. So, definitely uh, just trying to really to bridge and connect, public health and, healthcare. It is so important to make sure that you have them as a resource and they know that they have you as a resource. And for those EPIs that are pursuing your certification in infection control, I can't tell you how great it is when you have an infection preventionist giving you a call because they know that you're trained and you're qualified and they're letting you know, hey, we're kind of having this problem. I don't know if maybe if you have any recommendations. And it may not even be that they're reporting an outbreak. It could just be like, our C. diff rates are higher, or we had, an infection of serratia in the NICU, or it could be anything else, right? And they're just looking to you for guidance, and you're able to kind of bounce ideas off each other. That's a really special connection and a really great resource to have between public health and infection control. So for your long-term contamination of the catheter hub and luminal fluid is the predominant mode of bloodstream infections. So infusate contamination. So it's important to recognize that infusate parenteral fluid, blood products, or IV medications administered through an intravenous vascular device can also become contaminated and produce device-associated BSIs. Can anyone tell me what parenteral fluid is? TPN, yes, total parenteral nutrition, but what is that so that we can make sure we're all on the same page? Calories through liquid. Okay, yeah. Yeah, it's when your patients are getting TPN, that's how they're obtaining their calories and their nutrition. So, if you're not familiar with any terminology while you're reading the text, just make sure you're going through it and that you're understanding, because the CIC does have a huge clinical component, and you want to make sure that you're up to date with all of that clinical terminology. So contaminated fluid is fortunately an uncommon cause of endemic infusion-associated infections with most short-term intravenous vascular devices, and most healthcare-associated epidemics of infusion-associated BSIs have been traced to contamination of infusate by gram-negative bacilli. And so intrinsic contamination is when it's introduced, when it's manufactured. Extrinsic contamination, it's when it's introduced during its preparation and administration in the healthcare setting. And those are definitions that unfortunately you just need to know, because they may ask you which of the following would be considered an intrinsic contamination or extrinsic contamination, or they could say something like all of the following are an example of intrinsic infusate contamination except, right? And then they'll put the opposite one, the extrinsic one, as the except. Now, this is a picture in your text which goes over the routes for central venous catheter contamination, and you can see contaminated infusate extrinsic, which is the fluid medication, right? So this is when it's being administered, when it's being prepared in the healthcare facility, and then intrinsic, which is going to be your manufacturer. Contaminated catheter hub, endogenous skin flora. Extrinsic would be healthcare worker hands. For skin organisms, you have endogenous, which is going to be your skin flora, and then extrinsic is going to be healthcare worker hands and contaminated disinfectants. And so this is a really great picture that can, if you're more of a visual learner, that will help you put it all together. Now, let's do a quick concept check. This is one of the charts which goes over the pathogens that are most commonly isolated from intravascular device blood cultures, which are associated with intravascular device-associated BSIs. So true or false? Skin microorganisms account for the largest portion of intravascular device-associated BSIs. Okay, I know I made this one really easy. I know I made this one really easy, but come on, guys, it's Friday. The weekend's right around the corner. So the answer is vrai, which is true en français, right? I couldn't find the true one I usually use from Google, so we had to diversify it today. Oui, oui, yes. So yeah, that is true. And as you can see here, it's going to be your skin microorganisms that are going to account for the largest proportion of intravascular device-associated BSIs, which is why it is absolutely important that you're abiding with your bundles and that you're practicing all of those different, um, that you're abiding by all of those different measures. Liza says, I'm a trip. Come on, guys, it's Friday. We have to have fun, right? Education needs to be fun. So let's do another concept check. And this is going to be true or false. So recovery of certain microorganisms in multiple blood cultures, such as Staphylococci, Corynebacterium, or Bacillus species, or Candida, or Malassea species, strongly suggests infection of the intravenous vascular device. Staphylococci, Corynebacterium, Bacillus species. Uh, True. Very good. Yes, it's true. That is true. Vrai. J'étudie le français pour 7 ans, but that was like a long time ago. I studied it. I studied French for 7 years, but it's been a minute, guys. It's been a minute. Okay, so blood cultures should be obtained from two separate sites, at least one which is drawn from a peripheral vein by percutaneous venipuncture. Is this true or false? True or false? Interesting. So we have a lot of truths, but we do have some falses. So it is true. That is true. You should obtain your blood cultures from two separate sites. Can anyone tell me why you would want to obtain from two separate sites versus just one site? What is an advantage when you do two sites? Or what is the reasoning behind it? Oh, beautiful, Terry. Yes, in case one is contaminated. Very, very good. So most single positive cultures represent contamination, right? So this is really why we emphasize the need to obtain blood cultures from two separate sites when a BSI is suspected. Additionally, besides ensuring that you're obtaining it from two separate sites, is also ensuring that you're obtaining the appropriate volume so that the volume of the blood is essentially what you're needing. Now, I'm not going to ask you to remember what those volumes are, but they do tell you that in adults you should obtain at least 20 mLs, ideally 30 per drawing. So it's just important. It's an important part of you obtaining those samples. And so let's just quickly, I know we're a little bit over today, but this is important. It's all important, isn't it? It's just, we're saving people's lives. It's all important. So this is an example of, so what page is this? This is page 33. So this is the APIC guide to preventing central line associated bloodstream infections. This is definitely a guide that everyone should have in hand. You can download it for free 99 off the APIC website. So it's a really great resource. Let's go down to page 33 because I wanted to briefly just discuss a checklist that they have on here. And you can see this is from Johns Hopkins. And so they have different steps. So performing a timeout using the informed consent form, cleaning hands or performing hand hygiene, wearing your cap, mask, sterile gown and gloves, eye protection if in contact with or crossing the sterile field at any time during the procedure. And all others entering the room during the procedure must wear a cap and mask. And this all seems so easy and so simple, but I cannot tell you how many times I've been watching a PICC line insertion and the nurse will be doing her job magnificent, like just doing a magnificent job, but then someone will come in, not perform hand hygiene and start to don sterile gowns, sterile gloves. you cannot do that. And so this is why we have all of these checklists and bundles and different things in place to ensure things are happening correctly, prepping the site with chlorhexidine and letting it dry, draping the patient from head to toe using a sterile technique. So this is really where our IPs are going to have an upper hand for this exam, because they're utilizing these checklists, whether it's this one or whether they're utilizing the NHSN central line insertion practices. They're going to be familiar with these different steps. And so for my EPIs on the call, you need to make sure that you step it up with your clinical reading and ensuring that you are understanding the different clinical components of this exam. Now, let's just quickly end. I think I have like maybe one more slide. Yes, so some strategies to prevent intravascular device-associated bloodstream infections. You were previously talking about the choice of the catheter and site of device insertion. So data accumulated from numerous observational studies suggests that the lowest risk of intravenous vascular device BSIs is seen with subclavian vein insertion, and the highest risk with femoral vein insertion. And the intermediate is really going to be your jugular vein insertions. This is important. You have to know there's no way around it. This test is intended for infection preventionists, and they need to know if they're having issues, right, in one of their units, or if they're having problems in their healthcare facility. They need to understand what factors could be contributing to those issues. And if you have a physician that prefers to do femoral veins and his patients are getting BSIs, that is an issue, and you need to know what is going to put these patients at higher risk so that you're able to keep an eye on them, right? Then you also have your barrier precautions, which we of course went over on that checklist, right? Which is making sure that you're wearing your long sleeve sterile surgical gown, your mask, your cap, that your patient has a large sterile drape placed over them. I don't know how many, EPIs have seen like a PICC line insertion or any other type of, central line insertions, but it's pretty intense, right? So you just need to make sure there's a lot of steps. There's a lot of opportunities to mess up or to miss a hand hygiene opportunity, or to forget a certain step, which is why we have all of these different checklists, and that's all part of, patient safety and quality, which we previously reviewed. Your intravenous teams. So how well, an intravenous vascular device is inserted is really going to play a role on whether, it's a risk or not for the patient. And they mentioned this in the text. And that's why some hospitals have entire intravenous teams, which they are specially trained nurses and technicians who can assure a consistent and high level of aseptic technique during catheter insertion and in follow-up care of the catheter. And why do they use them? Because they have been shown to show substantially lower rates of catheter-associated BSIs, and that is cost-effective. So that's why they use them. And lastly, cutaneous antisepsis, which we did discuss. So our last question for today, and then we're going to end the call, is it is recommended to replace central venous catheters routinely. A, every 7 days, B, every 3 days, C, only when indicated, and D, never. This is really interesting because all of my nurses are getting this, all of my IPs are getting this correct, and my EPIs are all putting in the same, or the majority of you are putting in the same answer, which is incorrect. So you see, there's that clinical aspect of this test that is, let me tell you guys, there's no way around it. I watched a lot of YouTube videos. So it's going to be only when indicated. And our rationale is that current recommendations state that central venous catheters should be removed promptly when no longer deemed necessary, and the insertion site should be inspected daily for signs of infection. And the catheter should be changed or removed when catheter insertion site infection is suspected. So it's going to be only when it's indicated, right? Yeah, you should have been able to cross out never. And then your week 9 readings are the followings, chapter 27, 28, 29, and 30. You have to read those chapters. There's a lot of time. I mean, there's a lot of questions tied to these concepts that'll be sprinkled throughout the test. So make sure that you guys are getting your readings done. Don't just rely on class to cover these concepts, because like I said, I can't do it. It's a lot of information. So while I do hope all of these study sessions and group sessions are really helpful, just always remember that you putting in the time to complete your assigned readings and to ensure that you're understanding the education and the information that APIC wants you to know is going to be your best chance at passing your exam. Okay? All right, guys. Well, I hope everyone has a great Friday. I'm going to go bowling today, so I hope you guys all have a wonderful time. Say hi to your pets, your families, and get your reading done, okay? And if you didn't submit your homework, please submit your homework, okay? Because I need the data. Do it for me. If not for you, then do it for me. Okay, guys. See y'all next week, and take care. Bye.